go through normal bone physiology, there are going to be different disorders that will affect long bones, short bones, ossification, things of that nature. So the first type of bone I want you to remember exists is the long bone. And long bones are going to include things like leg bones, so like the femurs, the tibia, the fibia, arm bones, ulna, radius, and also fingers. The phalanges are long bones. So just keep that in mind that when we think of long bones, those are going to have this type of anatomical designation. So there's a couple of things that we'll look at. So there's the epiphysis, which is fun to say, epiphysis, and the diaphysis. The epiphysis is going to involve the uppermost and lowermost portion of these long bones. It does include the articular cartilage, and that word there, articular, that means having to or having an association with the joints. So when we think of arthritis, that's inflammation of the articular cartilage. So articular means related to the joints. Some other things that are associated with long bones are growth plates. We call them the epiphyseal plates or lines. This is what you can see here in these pictures. Remember, at puberty, these epiphyseal lines, they should close. So an open physis means that the bone has the ability to grow longer, but when these close, the bones cannot grow any longer, but they can grow thicker. They can get more compact. Inside of bone, there is trabecular tissue, so we refer to that as the spongy bone. So I just had a distal radius break, and I got to look at my x-rays, and I'll actually bring them to class. And you can see the trabecular bone, the spongier bone, starting to heal. So it almost looks like a honeycomb inside of the bones. And some things associated with these areas of spongy bone are located in the diaphysis. So the diaphysis is the middle portion of the bones. Remember, medulla is always the inside of something, where the cortex is the outermost area. So we call this area, for example, this is cortical bone, and the trabecular bone is inner. In long bones, there's a cavity, and that cavity is filled with things like bone marrow, where all the fun stuff is happening. Bones marrow is creating our blood cells from stem cells, and this is inside of the medullary cavity. There's a nutrient foramen. A foramen, just like in the heart, how there was a foramen ovale, which connected the atria, a foramen is just an opening so that there can be things like calcium, hyaluronic acid delivered to the innermost portion of the bone. And then there are different protective layers. We know endo means inside, so the endosteum is the innermost layer, this protective coating surrounding the medullary cavity, and the outermost layer of bone is the periosteum, so that means around the bone, literally. Also, bones have their own blood supply. So in the medullary cavities, there are vessels that are being trafficked through these different canals that exist in bones. So long bones, they have growth plates associated with them. They have marrow on the inside, and certain diseases affect long bones only and spare other types of bones. Another type of bone is a sesamoid bone, which is a bone embedded in a tissue. We all should have two of them with our kneecaps. Those are examples of sesamoid bones. They're connected to muscles, which are connected to tendons, and then the tendons, the patellar tendon, this is our patella, the kneecap, holds the kneecap in place. So sesamoid bones are bones embedded in another tissue. So the kneecaps are examples of this. But we have sesamoid bones in our hands, some of them in our toes. They're just embedded in another tissue. Okay. Other types of bones, we have flat bones, so those are neither long nor short, they're just flat bones. They're a little bit special. They include things like the scapula, so those are on your back. You can move them up and down, you can see them, they're on either side of this. If this is the spinal cord, the scapula kind of go like this, and that's what your shoulders are associated with. The scapula are attached to muscle, And so the muscles are what move them. Same thing with the sternum. The sternum is the breastplate, and the sternum has some marrow inside of it. And it also is a protective cavity that is going to be associated with the ribs. That's why you see those here. This is the xiphoid process down here. You might know that in CPR, you try not to knock that off because that can be fatal. But the sternum is another thing that is associated with muscle. These flat bones are. So the intercostal, extracostal muscles move the sternum up and down so that there's more room or less room for inhalation and exhalation. There's irregular bones that look really funny and they don't really fit into other categories. The vertebra are examples of irregular bone. We'll see that arthritis, osteoporosis does affect the vertebrae. The sphenoid bone is an example of that. If you look here, this is a cord, so you might have some idea of where the sphenoid bones come in. And then we have short bones. So these like little bones here in the hand. So we said that the phalanges, those are long bones up here, but these are short bones. So just keep that in mind that, again, there's going to be disorders associated with growth hormone, with ossification issues. If things affect the long bones, the short bones will be unaffected. The flat or irregular would be unaffected. So just keep that in mind where we have our short bones. Those are in the feet, those are in the hands, and in a variety of other places in the body. One of the first things you learned in anatomy and physiology was ossification, which to ossify means to harden, to turn into mature bone. So endochondral ossification is the beginning of bone development, which happens very early on in pregnancy, so well within the first trimester. So the first like 8 to 10 weeks, we're having all of the organ systems develop, including the bones. Bones begin as cartilage, so a cartilaginous model, which eventually starts to harden because it takes on calcium crystals. So this initial just cartilage matrix starts to get filled in with some calcium crystals so that it can start to turn into the variety of different layers we have in our mature bones, like the periosteum. Eventually, this becomes more and more compact so that we have hardened bone. This ossification center is at literally the center of long bone, so that it develops at the center as the strongest portion and then migrates in both directions, up and down. Early on, there's also the development of blood vessels within inside of this trabecular cavity or medullary cavity so that the bone can grow and receive its growth factors through the bloodstream. There's also secondary ossification centers around those epiphyseal plates. So keep that in mind because we'll talk about disorders that are going to involve early sealing of those plates. In a normotypical individual, these should develop unimpeded, definitely in utero, and then until the end of puberty. And when we're looking at a nice mature bone, we have, again, this spongier bone, this trabecular bone on the inside. We have this joint or articular cartilage acting as a shock absorber so that bones aren't knocking on other bones. And that's really important that the cartilage be there to protect the bone. Otherwise, the environment will start to damage the bone, like we see in arthritis, rheumatoid, gouty arthritis, osteoarthritis. We have our medullary cavity with the blood vessels and the bone marrow, and we have our epiphyseal plates. They mature first as discs, and then they turn into a plate. Again, that's going to seal at the end of puberty. So keep that in mind. We're going to, again, look at disorders with difficulties with ossification. And ossification is referring to this developmental process where we're going from a cartilage matrix to the development of a harder, compact, mature bone with all of the pieces in the correct places. When we think about bone remodeling, bones are constantly being remodeled. About 8% of your skeleton is remodeled every year, and that is going to involve a variety of different cells. You really have to remember one of these. If you remember one, you'll know the other. Blast means to build. So osteoblast, osteo means bone, and blast means build. Osteoblasts are the cells that build bone. They spit out a liquid substance called osteoid. Osteoid is like cement. So in the same way you make a sidewalk or a driveway, they pour liquid cement, and over time it hardens. And that's what osteoblasts do. They bind to a site on the bone. They're called hydroxyapatite binding sites. And the osteoblasts, they spit out this osteoid, this liquid bone, so that it hardens into nice, mature bone. So osteoblasts build bone. We call that bone deposition. They're depositing osteoid made out of calcium, phosphate, and a variety of things we call the ground substance, so it makes up the bone, like hydrolonic acid. All right, clast means to break down. So osteo, bone, breakers. Osteoclasts are the cells that bind to hydroxyapatite binding sites, and instead of spitting out liquid bone, they spit out proteolytic enzymes. So those enzymes are going to break down bone. When osteoclasts bind, they form something called a ruffled border. So if you look over here at this osteoid, like look how nice and smooth that is. That's nice, mature, healthy bone. Whenever there's osteoblasts working to build bone, there should be osteoclasts breaking down some bone so that you can replace it with fresh new bone. So osteoclasts, they can be stimulated by vitamin D whenever levels of calcium are low in the bloodstream. Remember, the bones, they're our bank for calcium. So osteoclasts can come, they bind, they form a ruffled border, and they chisel away at this bone, and they liberate calcium out into the bloodstream. So they're involved in typical remodeling. So if there's building, there's also taking down of things, kind of like building a new building. You need to take down the old structure before you build the new one. And then osteoclasts are also stimulated by parathyroid hormone, which is released when blood levels of calcium are low. Okay, so getting into that, the things that are most influential in bone remodeling, first off is parathyroid hormone. So parathyroid hormone is made by the parathyroid glands, which are embedded within the thyroid on the back. So the thyroid is like this butterfly-shaped gland, and if we look at it from the back, there's 4 parathyroid glands, and those glands make PTH. And parathyroid hormone, or PTH, is only released when levels of calcium in the blood are low. Calcium. And the bones, again, there are stores of calcium. So when blood calcium is low, we're going to need more calcium to run our muscles, to run our heart, to run all kinds of cells. So PTH, it stimulates osteoclasts to break down bone so that there can be calcium liberated into the bloodstream. It stimulates the kidneys in the renal tubule to retain calcium instead of peeing it out. And it also stimulates cells in the GI tract to not poop out any calcium. This is going to be all about retention. So we can break down bone to liberate our stored calcium. And the other things that parathyroid hormone does is signal to different organ systems like the kidneys and the GI tract not to get rid of any calcium that we need because we're low in calcium. You might remember that the opposite of parathyroid hormone is calcitonin. It is the yin to the yang. So whenever blood calcium levels are low, PTH is released. Whenever blood calcium levels are high, calcitonin is released. So calcitonin is made by cells in the thyroid called the C cells. C is for calcitonin. And C cells, they suppress osteoclast activity. They turn them off so that osteoclasts stop breaking down the bone and liberating calcium because now we have enough. So this is going to be something that helps maintain homeostasis. Parathyroid hormone raises blood calcium levels, calcitonin lowers blood calcium levels. In the same way that PTH triggers us to retain calcium, calcitonin triggers the body to excrete excess calcium so that we don't become hypercalcemic. This is your feedback loop. This is a physiologic feedback loop. It only has to do with the levels of calcium in the blood. Again, when calcium is high, we get the release of calcitonin. When calcium in the blood is low, we get the release of parathyroid hormone. So PTH stimulates osteoclasts to liberate calcium into the bloodstream. Calcitonin is going to signal to those osteoclasts to turn off when blood calcium levels are restored. Some other things that are important, you might know vitamin D is important. We'll talk about this a lot in this chapter. Vitamin D, we have the precursor for it in our skin, but in order to be activated, you have to go outside in the sun for at least 15 minutes a day without sunscreen. If you drive, usually driving in your car is enough, but cholecalciferol, vitamin D, our precursor has to be activated by sun. And when it is activated, it then goes to the liver to become calcidiol, and then it goes to the kidney where it's modified into calcitriol. And then it becomes this active vitamin D. Active vitamin D is cholecalciferol. That's our active form. And whenever vitamin D is around, it increases calcium absorption. Calcium and vitamin D, they go together in the same way that intrinsic factor binds to vitamin B12 so that we can absorb it. That's how vitamin D works with calcium. So you need to have vitamin D levels to have calcium being absorbed. If people are not getting adequate activation of their vitamin D because they are not going outside, they don't have sun exposure, they can take vitamin D tablets. They have to take the right amount. If they take too much, then you have too much calcium in the blood, which can lead to things like kidney stones, or it can lead to not as damaging of things, but muscle cramping, which eventually turns into muscle tetany, though. Growth hormone is what increases bone growth. Whenever growth hormone is released, it encourages long bones to grow. Once those plates have sealed, though, growth hormone just makes bones become thicker. Another important thing with bone metabolism is estrogen. Estrogen, as long as it's around, the active form of estrogen in the body is estradiol. It inhibits the apoptosis enzyme, caspase 3. So if osteoblasts become, worn out or tired, they will put up an apoptosis flag, like, come kill me, I'm tired, I don't want to live anymore. And then caspase 3, the executioner caspase, comes and kills the osteoblasts. So now they're gone. We don't want that to happen. As long as estrogen is around, it inhibits the executioner enzyme from just killing osteoblasts. So estrogen is really indicated in bone strength and bone density. So you'll see in menopause, when there's a big dip in estrogen, there's a big increase in fracture rates and an increase in osteoporosis. Thyroid stimulating hormone, it inhibits osteoclast activity, so it stops the breakdown of bone. And leptin is a hormone made by fatty tissue, adipose tissue, and it increases the number of osteoclasts. This is actually a fun thing in physiology. The more fat tissue you have, the thicker your bones have to be. So when people say there's no such thing as big boned, no, that's actually not true. When there is more adipose tissue, in order to support all of the weight that goes with adipose tissue, osteoclasts get stimulated to turn off, essentially, or to increase in their number, to help break down calcium from the bone, which will remodel the bone, making it stronger and thicker. So leptin increases the amount of osteoclasts to break down bone continually, making it stronger and thicker. So actually, obesity is a protective factor against osteoporosis because there's a stronger skeletal mass with a larger body mass index. And that's what you should know for just the physiology of the system. And then we'll talk about the pathologies in person.